Hey, I always leave it in the same spot. I'm the kind of guy that everything has a spot, so that's a spot.
It's probably in the first pocket.
It might be. All right, well, old school, I'm just going to do this. All right, so we went over those mild, moderate, and severe reactions, guys. Now, if a reaction does occur, we always know the very, very first thing we always do, and they will try to trip you up with these fancy answers. It doesn't matter how fancy your answer is, what's the first thing we always do? That's what happened with Monsi's patient. You discontinue the contrast immediately. Why? Because if they're allergic to the contrast and we're still pumping it in there, we're making the situation that much worse, and we could ultimately permanently damage or even kill our patients. Then, call for help, or specifically nurse and physician. We're going to access the patient's ABCs, that's the airway, breathing, circulation. Check those vital signs. Prepare the reaction kit and oxygen, that's the crash cart, by the way. And then be prepared to call that code blue. Notice what's dead last. Call a code blue. Why am I pointing that out? Because a lot of people always choose that first. That's not the first thing we do, it's actually the last thing we do, because patient care comes first. And they may not need the code blue. You might stop the exam and they get better immediately. Is there a need to call code blue after that? No, there's not. But all this happens very quickly. Keep in mind, it's not taking place like over an hour or anything. This is all happening like in succession. But keep in mind as well, they may give you answer choices that don't include all these. So if you had a set of answer choices that said, what's the first thing you do? And let's say number one wasn't an answer choice, but you saw number two would be that correct answer, because that takes precedent over the other ones. Y'all see what I'm saying? Does that make sense? So keep that in mind, know that order, but know they may not always include all those answer choices. But you need to know that order so you can choose the still first response based on the answer choices you have. Making sense? Very big star on that. I've seen questions exactly like that. Don't you hate when stuff gets moved out in spots? That just drives me nutty. A little OCD like that. Everything has a spot. If it's not in its spot, it can be 2 feet away from you and I still can't see it. It's not in its spot. Some of y'all are related to what I'm saying. Like I'll be looking for my keys and I have them on their spot, and my wife and I moves them like right here. Like, where's my keys? Where's my keys? Who moved my keys? She's like, they're right there. Why'd you move my keys? They have a spot. They go right there. Yeah. I'm a little OCD over that, yes. Please don't.
Oh my gosh.
You're going to give me anxiety. Okay, another adverse effect that we don't talk a lot about, but something you need to know, guys, is something called nephrotoxicity. Now, knowing your medical terminology and breaking down the prefix and suffix, what does that stand for? Nephrotoxicity.
Kidney toxicity.
Toxicity of the kidneys, which is, of course, a very life-threatening condition, especially if there's a severe allergy to said contrast. Because what happens with contrast is injected in the veins, it filters through the kidneys and is excreted through the urine. So, nephrotoxicity is the actual definition, that first bullet point, as a decrease in renal function following IV contrast administration. Now, how does that risk go up? If there is a pre-existing renal insufficiency, which is why we read those charts, is why we check those numbers. Which was the 3 that we checked, by the way? GFR, BUN or BUN, and creatinine levels. Yes, because if those numbers are off, that's indicative of some pre-existing renal insufficiency. And if there is any type of renal danger, we are not going to inject contrast, period. No matter how fancy they get on that question, if there's any risk to those kidneys, we will not administer contrast. Please keep that in mind. By the way, there was your answer there. You didn't have BUN, but this is why we test creatinine and GFR. And some other factors that can contribute to this nephrotoxicity, guys, is things like diabetes, or as Whipple Brimley says, diabetes. I showed y'all that video, didn't I? The old man saying diabetes. Maybe I'm thinking the other class. That's a very old commercial. when we were kids. Like you'd be watching Price is Right, and then the commercial would come on. This old man with a mustache. He'd be talking about, you may have diabetes. He said diabetes instead of diabetes. That's not ringing a bell? I guess I'm getting old. Okay. Well, diabetes, dehydration, which is why you've got to have lots of water prior to these exams. Heart disease, diuretic use. What are diuretics, by the way?
Something that remove liquid from the body.
We're going to remove liquid from the body, like this coffee I'm drinking. That's a diuretic. Tea is a diuretic. There are things that remove water. Age, of course, then multiple myeloma. Those are all some other factors that can contribute to that nephrotoxic reaction. I'll show you that commercial on break. If you don't know what I'm talking about. He was an old actor way many centuries ago that used to do these commercials about diabetes.
What is that? The following full contrast administration?
What is what?
Decrease in renal function following for contrast administration?
IV.
Oh,
Not Roman numeral, it's IV.
Oh, I see.
Intravenous, it's okay.
Stupid, my God.
No, it's not stupid.
Following IV.
Look, it's a Roman number 4, IV. It stands for IV. We're not using any Roman numerals in radiology, so it's okay. All right, moving on. Okay, water-soluble iodine. Now, these are the factors of what we call water-soluble iodine. Very common contrast medium that we're going to use in radiology. Part of your pharmacology, by the way. One of those medications we need to know for pharmacology and radiology. Now, it's characterized by a benzene ring. My chemists out there, y'all remember benzene rings? Y'all didn't take chemistry in college?
I did, but I don't remember.
I hated chemistry in college. Ugh. My Achilles heel of all knowledge is chemistry, by the way. I did not do well in chemistry class. But it's characterized by what we call a benzene ring. It's very safe for IV injection. So anytime you see a safe option for contrast, they're often going to use that terminology right there, water-soluble iodine. Please keep that in mind. It can come in the forms of ionic or non-ionic. We're going to break that down, by the way, because you've got to know the difference between those two terms, and we often forget those two. Also, being high osmolar versus low osmolar. More characteristics of those two mediums. Now, keep in mind, once again, this is going to be the most common form we see these characterized. Both of these are water-soluble iodine. We have two types, the ionic versus the non-ionic. One is safer than the other. One's also more expensive than the other. Let's talk about it. First off, ionic contrast. Why is it ionic? Because it actually breaks apart when we put it in a solution. So when we inject it in the body, those ions dissociate, that's the actual terminology, or break apart into multiple molecules. This is actually not desirable, but it's a cheaper option. Is it safe? For the most part, but it's considered less safe overall because due to the dissociation, what do you think happens more commonly with ionic contrast? It causes more what? More reactions, more allergies. Those reactions and allergies are caused by the dissociation of the ions. Does that make sense? Now, conversely, or on the other side of things, non-ionic, it's factors that will not break apart. That entire benzene ring stays together in one piece. Thus, because it doesn't break apart, it's the most safe option we can use, but it's always going to be much more expensive. Now, our hospital systems, they're rolling in the dough. They're going to use all those non-ionic solutions. We're talking about like cheaper hospitals or like third world countries. They don't have the access to the resources. They're going to more often opt for these ionic contrast mediums because that's what they can afford. Make sense? Yes.
Do our hospital systems opt for the
Non-ionic? Yes, they do.
for the reasons to, like, even though it's more expensive, it would be more expensive to go through a contrast reaction lawsuit or whatever. Like, God forbid something actually serious happened, and then they sue the hospital for all they got.
So these days, great question by the way, these days, despite the cost, they're mostly likely going to use these because, like you said, they want to avoid any kind of possible lawsuits. But we're talking about like other countries, third world countries, this is all they have access to. So that's all they're going to have to use. And they don't have the same kind of legal systems we have here. Something to keep in mind. Now, these used to be used a lot more back in the day, but because of the prevalence of those reactions, they've been phased out a lot more. We're pretty much only using non-ionic compounds. But despite that, please know the difference between these two guys. You've got to know the difference from the chemical reactions, the way they break apart, to why they are safe versus unsafe, and which one's expensive versus non-expensive. Please know those factors on the ionic versus non-ionic contrast, which are also called our water-soluble iodines. Water-soluble iodines.
We no longer use the oil-based, it was like the oil.
Yeah, we don't put those anymore. Injecting oil in the veins, that's not good for anybody.
Ionic, has more osmolar, right?
It does. It does. They're not going to ask you as much on that. I think I have a slide breaking that down more, but they're always going to focus for sure on this factor right here, the ionic versus non-ionic characterization. Know the difference right here, guys. That's why it's in red. Big thing to remember there. And they can ask multiple forms of that question to you.
What's the difference between the high osmolar and
We're gonna go over it.
oh, I thought you
Yeah.
And the,
Question, Shaheen?
So water soluble iodine, did you say that is the other name for contrast?
It's for our, yes, it's another name for the actual contrast that we're using here. Yes, yes. This all falls under that water-soluble iodine contrast. Okay, so a little bit more, guys. So ionic, great slide, by the way. I'll take a picture of that. I'll put a big star on that. Ionic is going to form the charged particles that actually break apart, like we were saying. Thus, because of that breaking apart, they have more allergy reactions, which is also what we call higher toxicity and higher osmolarity. Not osmolality, osmolarity. Those are two different words, by the way. Osmolality versus osmolarity. We're focused on osmolarity. Non-ionic does not form those charged particles. It stays together. Thus, it is safer, less reactions, lower toxicity, lower osmolarity, and that's the safest option. And to add to it once again, ionic is less expensive, non-ionic is more expensive to a hospital. Now what's osmolarity? If we want to define that, that's that concentration of solution expresses the total number of solute particles per liter. Basically how much ions are packed into that solution that we're using. So it kind of makes sense, if that's breaking apart, there's going to be a lot more molecules breaking apart, thus it's going to have a higher osmolarity versus staying together, we have less packed together, it's the safer option down here. But really good slide, guys, really good slide there. To break that stuff down. They have another one following that's really good if I'm not mistaken. I'm sorry I sound so gross, guys. It's bugging me.
what's the other word? Osmolarity?
So we have osmolarity, we also have osmolality, but we don't talk much about that one. We're just using osmolarity.
And then osmosis is the concentration from a high concentration to a low.
Correct. Correct.
Moles from high
So we don't really talk much
concentration
about
to
that one
low
either. We'll talk more about osmosis when we're talking about CT because we have the permeation through the membrane of all the brain's tissues and stuff. We're not there yet. So we don't have to worry too much about that one yet. Diffusion into the plasma membrane. Does that sound familiar? Yes.
So when I was reading osmolarity, it refers to osmosis only, right?
Say again?
It refers to osmosis only.
Don't worry about osmosis.
But it,
I just want you to focus on that.
just this
I
one.
want you, so when I say don't worry about something, guys, I want you to purge it from your brain because you're just going to overcomplicate it. Don't worry about osmosis. Focus on what this means and how it applies to these. That's all you need to know right now. Okay?
I remember being taught this thing.
Well, I'm trying to use osmosis right now to transfer this knowledge into your brains. I don't know if it's working, but we got little particles of knowledge that you should be absorbing. It's the osmosis
But
effect.
let's hear, but you're making yours, if you use the term osmosis, yours will get yours.
So, right? Well, speed it up, Melanie.
Well, I would have had this on my notes, Ms. Shepherd would have taught this, but she All of them slide
Oh,
up.
snap, okay.
Yeah, don't come for me.
That's why we're reviewing, that's why we're reviewing, let's not diss other teachers.
She's on retirement mode, dang it.
She was.
She had better stuff to talk about, like hairy chests.
How much she likes hairy chests? That always disturbed me.
That was
She
pretty
used to
crazy.
talk about that
yeah.
all the time. Like, Miss Trevor, I don't wanna hear any more about hairy chests. Please.
It was take off the shirt, even if you don't want to, for me, part. The what? There you go.
All right, another great slide, guys. Talking about our contrast medium once again. Please know these two terms. There's two on the left and one on the right. What is radiolucent and what is radiopaque? You've got to know the difference between those two terminologies. When we say radiolucent, it means like translucent. You hear the word translucent, what do you think of?
It goes through.
Kind of goes through it usually, right? Transparent. Well, kind of the same concept, guys. Well, first of all, radiolucent is going to apply to our negative contrast agents. And we have examples below. That's the easiest for x-rays to penetrate. And they appear what on films?
Black.
Very black, very good. So, what are our examples? Air and gas are most commonly what we use for negative contrast mediums. Now, what kind of complications can those cause? Because we always have risk no matter what contrast we use. Emboli, air pockets in the vessels. Obviously, air in the veins would be a big deal, a bad thing. And a lack of oxygen could be a side effect as well. Now, radiopaque, excuse me, on the other side, opaque means, what's opaque mean?
Can't see through.
Can't see through it, exactly, same concept. That's gonna be our positive contrast agent. It absorbs the x-rays, thus, when something's being absorbed by an x-ray, what color does it appear? Very white, at least it should. So something's radiopaque, it's not contrast, would be what? What's white on all our films? The bones, they're very radiopaque. But our specific contrasts, they can make certain areas radiopaque that are formerly radiolucent. Y'all see what I'm doing here? What's an example of an organ that's radiolucent without contrast?
Liver.
The colon, the liver, the stomach, the esophagus. But it becomes radiopaque when I introduce the contrast. Thus it becomes white, and I as a radiologist or a tech can see pathologies and do an analysis of that organ. Now see what I did there? Is that making sense so far? Now, what are examples of our radiopaque or positive contrast agents? Of course, barium, the most popular, barium sulfate, and our iodines that we just talked about, those water-soluble iodines. Both a positive, I'll get you in a second, Melanie. Both positive and negative can be used in the same study. What's an example of that? No, we haven't had fluoro yet.
Barium and gas or air.
Yeah.
Very good. So some of y'all have seen upper GIs where they not only drink the contrast, but they do the crystals. What's the point of the crystals? To introduce air into the organs and give us that, those two layers, right? You got the air and the contrast, and you can see the inside of the stomach. Same concept, we can do air contrast and radio contrast on our colons, our large intestines, to get that inside look of the actual colon, looking for polyps and things like that. Keep in mind, single contrast, you're only gonna see basically the outer portions of the organs, the internal organs. Double contrast allows you to see it internally because you got those two layers. Make sense? We good so far? Question, Melanie?
Yeah, when you, also when you said, with the colon, that it's a positive, or it's negative, but then.
Okay, so not so much contrast, no, so not something that's radiolucent versus radiopaque. So, the large intestine, if it doesn't have air in it, can we see it on a regular x-ray? We cannot if it doesn't have air in it, it's invisible. Air, yes, like there's gas, because air is a contrast. But let's say I have no air in my colon, I'm just completely, I'm cleaned out, I got nothing going on. Is my large intestine visible on a regular x-ray?
No.
It is not. Thus, we can't see it, it's radiolucent, it's invisible. Now, when I introduce contrast, then I can see my large intestine, correct? It becomes radiopaque when I introduce the contrast. I was just showing you another way to get questions on those two terms right there.
So if it's radiopaque, it's gonna be white, right?
Radiopaque is white, radiolucent is black. We're on contrast. Jay, do you have your hand raised?
No.
You good?
So you said with the contrast, once you would you give it to it, it might
So it starts off radiolucent first.
It's about like things, not everything, just certain organs, like your stomach, for example, your intestines. Unless there's air in there, you're not gonna see them on an X-ray.
Okay, yeah,
Thus,
right.
they are radiolucent.
Yeah.
But when I introduce the contrast, there's something to absorb, and it
It
becomes
lights up.
radiopaque.
Okay, yeah.
Now, bone, it's naturally radiopaque. It's
Oh,
always
yeah,
white.
it's white.
Mhm.
What is it called again when you have both positive and negative? It's called
That's a double contrast study,
Oh.
which is important to know, by the way. Those green shoes are really cool. Those green shoes are
Oh,
cool.
thank you.
Like they'd be like really glowing like a black light.
Oh, yeah.
Like,
I
yeah.
was hoping.
It's hoping it.
Yeah.
That has black lights in the room.
Oh, yeah.
Has
Well,
a lecture with black lights.
Double contrast.
It says lack of oxygen.
So if we introduce too much CO2 into someone's system, it can actually counterbalance the oxygen and screw up the balance of equilibrium. You don't want to pump too much air into somebody, it can actually cause damage. Okay, some popular, we're still going, I guess I should put all this under the pharmacology section, but this is where pharmacology stuff you gotta know, guys. Popular contrast choices, of course, the most popular we all know is the wonderful, tasty, chalky barium sulfate. Did no one's tried barium sulfate yet? I'm so disappointed. You'd probably get in trouble if you did that, but I will admit, because I was quite the student when I was in school, I tried some barium sulfate. I was curious.
you tried the vanilla kind or?
But it wasn't
Industry?
flavored.
It wasn't flavored.
No, it just tastes like milk and magnesia. You ever taken milk and magnesia?
It's flavored now.
Yeah, that's what.
Now, we used to make chocolate milkshakes for the kids with barium sulfate, but it sure don't taste like a chocolate milkshake. But psychologically, we tried to make them think it was a chocolate milkshake because we had the Hershey syrup and we mix it in the barium, make it look like chocolate milk. Here, it's just a chocolate shake.
With nature.
For kids.
It depends on the kid. They'd be like, it's like really thick. It tastes funny. I swear it's a chocolate milkshake. It's good for you. Now, the toughest thing to do was when we got to things like the oil-based iodine, because some kids, they were allergic to barium sulfate. And I've tried this stuff too, because I always say, I get appreciation for what my patients go through if I know what it tastes like. A water-soluble, like iodine contrast, it's like just drinking bitter cough syrup. It's got that really oily, thick, syrupy texture, and it's just pure bitter. So when we tried to go psychological on that one, mix that with chocolate, I mean, it looked like chocolate, but as soon as that hit their tongue, no, there was no amount of sugar to save that. So that didn't work so well. But anyway, I'm sorry. Our popular contrast choices are going to be our barium sulfate, air gas, CO2, oil-based iodine, which we don't really use those anymore. That's an old school contrast. And then our more popular water-soluble contrast agents. If a patient cannot use barium sulfate, we're always going to opt for what of these four? Those water-solubles, correct. So, if I have someone that's doing an upper GI, it's a great question here, guys. I have a patient that's presenting for an upper GI. We find out via the chart that the patient is allergic to barium sulfates. What is the name of an alternative contrast beam that we can use if they don't say water soluble? Y'all know a name for it? Like an actual medication name. We're gonna go over these, by the way. So you may not. I don't know if y'all went over this in class, but has any Visipake would be one, correct?
No, I'm
Gastrographin, y'all seen gastrographin? Or gastroview? So there's a way that you can figure that out if you don't know them exactly though, guys, by the way. What's the word gastro mean? Gastro,
Stomach.
not gas. Gastro refers to stomach. So if you see the word gastro, those are only used for upper GIs. So you can be sure, you can always choose something that says the word gastro. See how I've simplified that a little bit more? So if you're going blank, like you're panicking, wait, gastro means stomach, that's an alternative. On the other hand, what would be a water soluble we use for the bladder, I think? So we had gastrographin for the stomach. What's something we use for, well, we haven't had fluoro yet. I want to see if y'all can figure this out. What's something we can use for the bladder? Any of you have done cystograms? There was a key word there, by the way.
Cystographin.
Cystographin, because what's cysto mean? Cysto means bladder, graphin's the contrast. Bladder contrast, cystographin. Grammar can save your life, guys, I'm telling you. English class was important in school, I promise.
Graphin system.
Yeah, it's just some examples there. Did someone raise their hand? Jay?
So those are with suspected perforations?
Say again?
Those are with suspected perforations?
That is thank you, Jay. Actually, that's why I have a star on that. That's a very popular registered question that you're gonna see, guys. By the way, what's a perforation? It's a hole or a tear. Now, critical thinking. If I have a tear or a hole in any organ in my body, am I going to use barium sulfate?
No.
Why not?
To leak into the system.
It's going to leak and it's going to cause what? Not extravasation, but an infection. Barium cannot leak outside of cavities. It's not safe. But once again, what are those safe options for allergies and or perforations? I didn't mention this before. That last one, water soluble. Water soluble is so safe that it can leak into cavities and still be okay. It's not going to be comfortable, but if I have a leak, like a hole in my colon, and it's leaking out into my abdominal cavity, it's not going to kill me, it's not going to hurt, it's not going to cause damage, but it's just going to cause discomfort. So any suspicion of perforation, and they'll ask this question in a million different ways. It's one of their favorite questions to ask. You see that word perforation, your mind is a default to bullet point 4. Water soluble iodine contrast. Yes.
Can you give me some synonyms for perforation?
Some what?
Synonyms?
Synonyms for perforation? Suspected tear, hole. I mean, they're probably not going to use that simple terminology,
But how would you fix those?
scarred maybe, scarred colon, scarred stomach, which can lead to a perforation.
You would fix those with grafts, right? Like skin grafts or whatever.
Mhm.
So that's another way to think.
But to really go back to what they're most commonly going to use, guys, they're going to use that word perforation. That's the most common phrase you're
I
going
was
to see. on
saying
that.
to like gastrografin so that you learn
Oh.
the second part.
It's a good way to remember it. I like that. Yes.
So what if they give the question and they say there's a perforation, and they have, one of the answer choices is not water soluble, but it's like non-ionic or, non-ionic.
That's a very good example. I'm glad you're doing this. What I want y'all to start doing is thinking of alternative questions. That's a great question. So Melanie just said, what if they don't say the word water soluble, but the answer choices are non-ionic contrast or ionic contrast? Which do you think would be the best option? But why? It doesn't break apart. It's going to cause less reactions. Correct. Correct. Very good. Very good example question. I like that. Might have to throw that on the test. You can thank Melanie for that really difficult test on Tuesday that you're going to have. No, that's what I want y'all to do more of, guys. Think of alternative questions. That's how you're going to be successful in this registry, because they can ask these things in any number of ways. Very good. Do you have a question, Shaheen?
Listen, since air and gas is always carbon dioxide.
What now?
Air and gas is always carbon dioxide. So when you refer to air,
Is it always? Yes, it's going to be carbon dioxide.
it's always going to be carbon dioxide.
That's what we're going to introduce into the body, yes. We're not going to pump oxygen in there, no. It'd be a big no-no. Although some people love to go put those little oxygen things in their nose and say
You know,
it's
man-
low for hangovers, but
When I all this time was thinking of air, I was thinking of the air that we breathe, so with everything. It's not that air that what we breathe. It's carbon dioxide.
correct. So we breathe in oxygen and we emit
Yeah, but
what?
carbon dioxide.
But we're going to introduce carbon dioxide for a contrast purpose. Yes.
Thanks.
We're not going to use oxygen for contrast, no. Okay, so talking about medication once again, guys, what are the most popular routes? Please make sure you know these. So, first of all, when you see that word parenteral, they're going to use this a lot on questions. What does parenteral mean? That is administration of medication by injection into body tissues. Now, that doesn't mean one particular way. That's the general term. Parenteral is injection into body tissues, which covers a large spectrum, by the way, because we have lots of different tissues, yes?
Yes.
But please know that term, that has been showing up quite a bit. What are some examples? Subcutaneous, what's that mean?
Under the skin.
Under the skin. What's an example of that? What's a subcutaneous injection that all of you have had before? At least you should have. TB test. What do they do, guys? They put that needle right under your dermis, create a little bubble, right under the skin. It's a subcutaneous injection. We've all got TB tests.
You gotta check that.
I think they did the TB test. They did the TB test here. but
Usually,
they didn't do it like
if
that.
you haven't had it now, before you start your job, you will have a TB test.
I've had it, but they
Oh.
didn't do that. What you saying? They didn't do that.
Well, they may have had it on your record already. You don't have to have it like
No, this
that often. You don't even do it once a year. I haven't had mine in 4 years, so. Thanks per area, I don't know. But. Anyway, let's keep on track. Next one, intramuscular. It's in the word, guys. What's that mean? Into the muscle. What's an example? Hey, no, true. The flu shot is intramuscular. A penicillin shot in the butt, which is very painful from what I hear, is a intramuscular
From what I hear.
shot as well.
You know what I
And still getting
mean?
penicillin shots in the butt muscle. At least that's what I've heard. The gluteus maximus, if you want to be more.
It's not that bad.
It's not that bad.
Clench really hard and.
That would be the worst thing to do. You never clench up for a shot. All right, pro tip, guys, never tense up for a shot because your muscle gets very hard. It makes it harder to put the needle in. Relax.
When I got my COVID
Now,
shot,
one that we should all know, of course, guys, is the intravenous into a vein. Then we have a different type of under the skin. We have intradermal, which is in the dermis just under the epidermis. And those are our 4 most popular parenteral injection types, guys. Yes.
Do we need to know the degree of entry? Like
The only one you need,
intramuscular
so good question. The only one you need to know is intravenous, which is what?
30 degrees.
25?
40,
Oh dear.
15.
15.
15.
15.
Is IV the most common out of all the 4?
That's gonna be the most common that you use in radiology
Oh.
for contrast exams. You're not gonna be giving intramuscular shots. You're not a nurse, so you're not gonna be doing TB tests. Don't worry about any of that. But you need to know what they are.
give me an example of intradermal.
I was trying to think of one off the top of my head. That's gonna be a
Confused between
more.
the subcutaneous and the intradermal.
I'm trying to think. I'm failing to think of an IT injection. It's a little bit deeper. It's under the
Yeah, I
epidermis.
think that's deeper. It's only in the epidermis, the intradermal is only the epidermis. It's the first layer would be, right? Into the epidermis. So,
I cannot think of an example of that off the top of my head. Just so it's a little deeper
About
under
tetanus.
the epidermis.
Do you need to know the needling for this?
No, but do know the gauges. Do you remember needle gauges? Smaller number equals what?
Bigger.
Thicker needle. And the larger the number. So you want those big gauges, right? Like those butterfly needles. That's the ones that don't feel so bad. You see them break out that one gauge, it's like a bullet. You're like, oh my God. I donated blood a couple months ago, and I swear she must have used a 1 gauge. That needle was so thick. I was like, oh my God, that's gonna leave a hole in my arm. Huge. It was huge. That thing hurt, man.
That's because they
she
went
wanted more blood and like going faster.
That thing hurts. I guess she wasn't very confident. I don't know. She needed that big needle, I guess. And she stuck me good.
You cut her off in traffic.
Huh?
You cut her off in traffic.
I must have. All right, so once again, some more routes for medication, guys. Once again, remember, parenteral is the overall term for injection. We have oral, means by mouth. Buccal, behind the lower lip. We have sublingual, lingual.
Under the tongue.
Lingual, you have to use, think about this, to say lingual, you have to use your tongue, lingual. And topical is on, not under, on the skin like a cream. And then of course we have our drip and bolus injections. What are the difference between these two?
The drip is it the IV drip?
Like an IV drip. So a drip is a controlled amount that you set that literally drips the medication like an IV bag, like a saline bag, I mean. It's just dripping into someone's veins. What's a bolus?
A large amount at one time.
That's any amount that I'm injecting is one injection. So I can have a bolus of 10 cc's, I put it all in at the same time. I can have a bolus of 50 cc's, I inject it all as one. You know, you see, like you inject the flush,
Like
that's a
you do it-
bolus injection.
Oh.
Versus they have a bag that's dripping a certain amount, that's that drip injection. Making sense?
Drip, drip.
Oh, I saw a bunch of, who was first?
I thought buckle was like right here on the cheek, not on the lower.
Buccal can go, so you can add this to your notes. Most commonly it's behind the lip, but it can go all the way around. It's all still considered behind your lip. It needs to be in the lower portion though. You're not going to put it up here. That's not going to do any good. You want it to be down here towards the gums where the salivary glands are. Because the point of a buccal root is to have your salivary glands absorb it into the body. So that range of behind your lip, guys, that can go towards the cheeks as well.
And parenteral, isn't it like anything except for the digestive, like any route except the digestive tract?
So parenteral is gonna, it's any type of injection, actual injection.
Is
So
that
it's gonna be,
like something like a port or something?
that would still be an injection.
Oh.
So that'd still be parenteral. It is an actual injection, is parenteral. Okay, still good?
No, you're right, it's not to the mouth, we had a question there.
All right, so just a little bit more on the IV administration, guys. This is all falling under pharmacology still. Our three methods are the slow injection rate, the single administration route. That could be by an intravenous bolus, which is the large, or the amount all at the same time. We have the administration of a large volume and they drip. So I just want to make sure we're differentiating between the two. When you're getting an injection, an IV administration, that can be in the form of a bolus or a drip method. That's the two ways they're going to do that. You're never going to do like half and then half. You're going to have a controlled amount dripping it in, or you're just going to inject it all at the same time. If someone ever like gives you an injection, they like put a little bit in, stop, a little bit in, stop, they're doing it wrong. Go find somebody else to give you a shot or whatever you're getting. That's a big no-no. You need, and there's a reason you don't want the medication to be intermittent unless it calls for it. So if you're supposed to have some all at once, it needs to be all at once. If it has to be a smaller amount, you're gonna go for that drip controlled amount. There is a big difference between the two. You're only gonna choose one of those two.
So what's the difference between 1 and 3?
1 and 2.
1 and 3.
Oh.
So a little overlap there, guys. I know it's saying three methods. Slow injection rate with a single administration route kind of falls more so with the drip infusion because we're controlling the amount that's going in. I should have put three methods. There's just two, guys. There's two.
No.
You either have a bolus or a drip.
Okay.
That's sorry for the confusion there. By the way, once again, one of my arch nemesis, I already talked about this on Tuesday. I swear every nurse that ever sends a patient to me, they send them over with these drip bags with the freaking monitors beeping. Am I the only one?
Yeah, they all.
Every patient I ever get has a monitor beeping on that drip infusion. I have to always silence it.
I didn't know how to work it one time, and so I just went off.
You're allowed to hit silence, just don't turn anything off.
But one time it said bubble in mine or something
Oh,
like that.
when you let the nurse know when you see that.
Yeah.
That can
I
cause
was
an
with the tech
issue.
though, and he just turned it off. I was dying.
If you see there's an obstruction or a bubble, please tell the nurse that. That can actually cause damage. If you get bubbles inside your veins, it can actually kill you. Yeah. Big no-no. A little bit more on the drip infusion. Once again, that's used for our very large volumes. As you can see with a big bag, you're not going to do a bolus that size. You're going to blow their veins up. You would not want to inject that much at the same time. So it's going to be our large volume fluid. And of course, I did put on there, pay attention to IV pump alarms. You are allowed to silence it when it's running low. Do not silence it and turn it off if there's a bubble or an obstruction. You want to do what? Report it to the nurse. Make sure they're aware of it so they can come fix that. Common sense, should be common sense there.
Do you also use the drip one for large patients? Or
Not
you use?
necessarily, it's just for large amounts.
Okay.
And mostly for like our saline and things like that. That's the main reason you're gonna use drip infusions. Bolus is more for actual medications. Not to be confused because some drips can be medication based, but most commonly the bolus will be medication and
Excuse me, sir.
the drip will be more like fluid hydrating and saline and things like that.
So-
Question?
So, drip infusion can also include when you can't take by mouth, that's when they give you
And
drip, right?
if that medication is allowed to be delivered as such. And the majority of our medications, once again, are gonna be a bolus injection. Now think about, you take a medication as a pill, you're not gonna like take a third of it here, the next part here, the next part here, you're gonna take it as a whole pill. At least I hope you do.
What if I can't? There's some pills that I
As
get
horse
that I couldn't
pills?
have yet.
Yeah, I choke on it too.
I have to cut them in half, I can't.
I suck at taking pills. I'm always choking on one. I take my little fish oil, well, not little fish oil pills every morning.
Yeah, thank you.
Like, ugh. Trying to get it down my throat. Like, they're huge, but they're good for your heart. They're good for your heart.
Have they ever like popped in your mouth? That's the
No,
worst.
do not pop a fish oil pill in your mouth. You'll regret
I threw
it.
up when
It's
I
actual fish oil. It tastes like
Yeah.
a fish. I've got some on my hands. I mean, it's fish. It's
When
nasty.
you burp,
What is the fish oil help for?
It's good for your
your
heart.
heart.
In your
Good for
brain.
your heart. Good for your cholesterol.
I guess I'm gonna have a bad heart.
What did you say about the drip? I mean, was it the trip? That's the best one to use or something? What did you
No,
say?
so I said for medications, usually the best way to do it
Okay.
is the bolus.
Oh, the bolus. Okay.
Yes. Same with like if you take liquid medicine, you're not gonna like sip a little here, sip a little there. You're gonna drink that whole little cup of medicine, right? You're taking
Nice.
some what's the
Like a shot.
what's that
Mucinex.
Codeine.
not Mucinex, what's that
Motrin?
Motrin.
what is it?
NyQuil.
NyQuil, that's like a shot of alcohol.
Yes.
What you be
I'm
doing,
thinking
Marcy?
of amoxicillin, that's what I'm thinking of, amoxicillin. You've all had amoxicillin before?
In
You
a
had
pill form.
Infection?
Yeah. In a pill form.
They have it in liquid form too. I've had to give it to my kids.
Oh, why you do
Is that the brown bottle?
By the way, it's, if you have kids and you're struggling to get them to drink a medication, the best thing you can do is get your little syringe and you put it back here behind the cheek, like a buckle, and they'll naturally, like, as a reflex, swallow it, even if they don't like it.
Put it in the
I used to
bottle.
do that all the time for contrast studies with babies. Stick it way back there and inject it.
Andrew, I stick it like at an angle to the back.
Yeah, put it in that bottle.
Is it
Okay,
on
I'm gonna
the
go
table?
forward on the, yes,
Then what's an IV pump?
what's an IV
A
pump?
pump is the one that they use in the morning. Not the one
That's an
that
IV pump.
the one, oh yeah, yes.
Those annoying things that beep all day.
That's all.
That is all. Okay, some more vocabulary, guys. So those key terms, please write these down.
Me in the hospital.
As you look at that nasty GIF of the girl
That's me at the hospital.
viewing that boy with snot coming out of his nose.
That's me.
That's
Okay,
That's
just-
the actual term.
I just had to
We'll get
check.
that. I'm gonna get that's the actual scientific term.
Okay.
Okay, so the ones we're going over here, guys. Microorganisms should be self-explanatory. That's living organisms too small to be seen with the naked eye. That's things like our bacteria, our protozoa, our fungi. What else? Our viruses. All microorganisms. Micro equals small organism.
Thank you.
Then we have our pathogenic microorganisms, an extension of microorganisms. They're capable of causing infection or disease by destroying cells or tissues or secreting toxins. So what's some examples of those, guys? COVID. That's a pathogenic microorganism. What else? The flu. Anything else? Streptococcus.
STD.
STDs, yes. Gonorrhea. Whatever you want to think about, yes.
That's whatever you want.
Now, yes, this is not being insensitive, it's the actual term, guys. Antisepsis retards, which means slows, the growth of pathogenic microorganisms. Now, I know that's not a term we use because that can be a very offensive term, but scientifically, that's what that actually indicates. It retards the growth of pathogenic microorganisms. Medical asepsis and surgical, guys. Big gold star on these two. I see people mix these up all the time. And there are a lot of questions to be asked of these two. Medical asepsis is the destruction of pathogenic organisms through the process of disinfection. Now, when I say destruction, does it mean it's all gone? It does not. We're only removing most, a large majority. Now, conversely, if I see surgical, that's the removal of, keyword, all organisms and their spores, and it's practiced in our surgical suite. So do I do surgical asepsis in my x-ray room?
No.
I can't, right? There's no way. This calls for actual sterilization procedures. So this is specific to our surgical procedures. This is what we all do, at least we should be doing on a daily basis in our x-ray rooms. Now, once again, I want to make sure we're clear. This is destruction of most, but not all, because we cannot get rid of all of them. It's not possible. Whereas surgical asepsis actually does, at least from what they tell us at least, does get rid of all the organisms through sterilization. Disinfecting is not sterilization. There's a difference there. Disinfection falls under medical, and sterilization falls under surgical. Please know the difference between those.
Medical is like the clean technique, and surgical is the sterile.
Mm-hmm.
Like the dirty.
Exactly right.
Like sterile processing, like sterile processing, you have a clean side, you have a dirty side.
Exactly. Now you stay away from the blue, 'cause it's all sterile. You see blue, you stay away. Anyone bumped into it yet? I can admit it. I bumped into it a lot as a tech. They chewed me out too.
I was.
I'm clumsy.
Mr. Omni, I'm sorry, but.
I'm sorry too. I don't know what for, but
No, I'm like,
I know he loves skater.
yeah, he loves sitting right there, I'm like,
no one's bumped. I'm the only person that's broke sterile film. Sorry. Seriously?
I saw a resident drop
Y'all just
something,
experts then, aren't you?
and they asked if it was still sterile.
He said yes.
No, they dropped something that was on the table, like,
Oh, wow.
and then they asked after picking it up, saying, "Is this still sterile?"
3 seconds. Not sterile no more.
What-
No, it's a 3 seconds.
All right, let's take our first break, guys. Let's take our first
Take
break.
COVID.
It's 9 o'clock. COVID.